So I am going to kick off the meeting now because we have a full agenda. So I'm going to actually at this point stop sharing my screen so that Jonathan can also feel comfortable getting his slides up. So welcome everybody to day 2 of New Horizons. Yesterday we were going along the history over the past 20 years, and now we are in the present day. And so it is a pleasure to introduce 3 doctors who will be giving presentations this morning. We will start with discussing current treatment options. Dr. Jonathan Noujaim from the University of Montreal is going to start, and he is the sarcoma lead with the multidisciplinary sarcoma team at his institution. Then we're going to be having Dr. Yoon-Koo Kang, who is also the sarcoma lead at Asan Medical Center in South Korea. And he will then transition to discussing access issues that I'm sure many of you can identify with, and we will have a discussion around that afterwards. And then after he speaks, Dr. Samir Rastogi, who leads the sarcoma team at AIIMS New Delhi Institute in India, he's going to be giving a talk as well. So it is a pleasure to have everybody here today, and I would like to turn this over to Dr. Noujaim to begin.
Good morning, good afternoon, or good evening, depending on where you're joining us. So I thank the organizers as well as the Life Raft group to give me the opportunity today to talk about the current treatment options we have to treat patients with GIST. The good news is that the options are continually expanding, and we'll touch a bit of each. Here are my disclosures. So in the next 15 minutes, I'll briefly update on the role of adjuvant imatinib for localized resected GIST, but I'll go more in depth in the current standards of care for managing advanced GIST. So in the adjuvant setting, nothing has changed much since the landmark trial done by the Scandinavian Sarcoma Group that looked into comparing 1 year of imatinib to 3 years of imatinib for higher risk GIST determined by tumor size and mitotic count. And then the last couple of years, the 10-year update showed that 3 years of imatinib showed quite a relative improvement in recurrence-free survival, going from 42% for 1 year patients of imatinib to 53% of recurrence-free for patients receiving 3 years of imatinib. And at the 10-year mark, the overall survival, the benefit has increased, going from 65% for patients receiving only 1 year of imatinib to 79% for patients receiving 3 years of imatinib. So for now, adjuvant imatinib 3 years remains the standard of care and will not change for the upcoming years. So now let's take a look more in the advanced setting. So as you well know, gastrointestinal stromal tumors are activated tyrosine kinase driven tumors, and the 2 major players are the KIT and PDGFR, with a majority of mutations happening in the exon 11 of KIT, activating the tyrosine kinase inhibitor. So prior to the introduction of imatinib, gastrointestinal tumors were quite challenging to treat with conventional chemotherapy, did quite poorly until the introduction of imatinib. So imatinib is a selective tyrosine kinase inhibitor, which its goal is to block the linkage of the ATP to the tyrosine kinase, therefore preventing it from activating subsequent signaling pathways that drive tumor progression. And the clinical benefit of imatinib was highlighted by 2 major trials, one led by the ERTC group that compared 2 different doses of imatinib, one being 400 milligrams and the other being 800 milligrams once a day. And they've shown a significant benefit in progression-free survival, hovering around the 2-year mark. And this was also translated in a major overall survival benefit, both groups being comparable around the 3.9-year mark. So As a reminder, where we left off, compared to the historical patients treated with doxorubicin, the introduction of Imatinib in advanced GIST was a major breakthrough. Subsequent genotyping testing done in different patients on trial have shown that patients carrying an exon 11 KIT mutation had a better favorable prognosis compared to patients with exon 9 mutations. However, the exon 9 mutation patients could be overcome by increasing Imatinib to 800 milligrams once a day, and now today proves a standard of care for patients progressing either on 400 milligrams or being started right off the bat at 800 milligrams for patients with exon 9 KIT mutations. So to summarize Imatinib in the first line, at the 10-year mark update of these trials, I'm happy to say that more than 20% of patients are still on therapy and still maintaining long-term remission. However, unfortunately, more than 10% of patients will present upfront with a primary resistant mutation to Imatinib and therefore represent the group with a high unmet medical need. However, more than half of patients in the first couple of years of being on Imatinib therapy will finish by progressing, and the reason for that is the acquisition of secondary resistant mutations. So these mutations happen and span around between exon 13 and exon 18. And then as a reminder, Imatinib links itself more in the juxtamembrane domain. So mutations happening further down manage to activate the tyrosine kinase despite being linked to Imatinib. And with the advent of other tyrosine kinase inhibitors, Sunitinib managed to overcome, to a certain degree, these secondary resistant mutations. So compared to Imatinib, Sunitinib is what we call a dirty tyrosine kinase inhibitor because it does not only inhibit the KIT and PDGFR signaling pathway, but also other signaling pathways, including the VEGFR signaling pathway, which is quite predominant in numerous cancers. So the clinical benefit of Sunitinib was highlighted by a phase 3 trial comparing Sunitinib at 50 milligrams once a day, 4 weeks on, 2 weeks off, compared to placebo. And time to tumor progression was improved with Sunitinib going from 6.4 weeks in the control arm to 27.3 weeks in the Sunitinib arm. And this translated to an overall survival benefit with a median overall survival going from 14.9 months to 17 months. And I always like to look at real life data and compare it with clinical trial data. And this is data coming out from the Life-RAF registry group. And we could see that with the introduction of Sunitinib in the second line, there was a definite improvement in survival for GIST patients. So for the last 10 years, Sunitinib has been the current standard of care in the second line, but thankfully, it is now being currently challenged with a new drug called Ripretinib on the basis of the INTRIGUE trial. So INTRIGUE is looking at comparing Sunitinib to Ripretinib in the second line. And I had the opportunity to put patients and enroll patients in this trial. So the trial is currently closed and we're waiting for data to mature. And hopefully this will create a new standard in the near future. So for patients progressing on Sunitinib, third line standard of care remains Regorafenib. So Regorafenib, similarly to Sunitinib, is also a dirty tyrosine kinase inhibitor, not only inhibiting the KIT and PDGFR pathway, but as well as different other pathways, including the RAS-MEK pathway. And the benefit from Regorafenib was highlighted in the GRID trial. So this was a phase 3 trial comparing Regorafenib at a dose of 160 milligrams once a day, 3 weeks on, 1 week off, compared to placebo. And in this trial, crossover was permitted therefore sometimes muddying the interpretation of survival data. So there was a clear benefit in progression-free survival for patients progressing on sunitinib, with a median progression-free survival going from 0.9 months to 4.8 months for patients receiving regorafenib. At the time of publication, no difference in median overall survival could be discerned. However, as the years went on and the data matured, with some mathematical gymnastics, they were able to compare. So for patients receiving only placebo, the median overall survival was less than a year, compared to 17.4 months to those patients receiving regorafenib. And again, data coming out from the LifeRaf registry, we see that the introduction of regorafenib by 2013 in the third line has dramatically improved also survival in patients. So what's interesting is that once patients progress after 3 lines of therapy, when you do analysis on the circulating DNA for these patients, we see that secondary KIT mutations remain the predominant mutations driving tumor progression compared to primary KIT mutations. Therefore, it's quite logical to assume that if we had better drugs targeting these secondary resistant mutations there, we could improve patient outcomes. So until recently, my talk would have been finished after 3 standard lines of therapy, because at the 4th line, there was no convincing drug that was considered standard of care, and it was a bit dealer's choice at this point. And for accessibility issues for other tyrosine kinase inhibitors, we used to keep patients on regorafenib even beyond progression because there was certain benefit there. So the standard of care in the 4th line was finally defined via the Invictus trial that randomized patients progressing after 3 lines of therapy to ripretinib at 150 milligrams once a day compared to placebo. In this trial, there was a possibility of dose escalation to twice a day for patients progressing on ripretinib, as well as crossover from placebo to ripretinib for patients progressing as well. So ripretinib was designed as a broad spectrum KIT and PDGFR kinase inhibitor. Its goal was to inhibit the full spectrum of primary mutations as well as secondary KIT and PDGFR mutations known to be resistant. And how it does that, it's by binding to the activation switch and the switch pocket, regardless where the mutation is, and that binding of ripretinib to the kinase prevents it and locks it in this inactive state, therefore inhibiting any downstream signaling pathway that drives tumor progression. So looking at the patient population in the Invictus trial, we see that the population was quite representative of clinical practice, with a majority of patients having ECOG 1 or 2. And this was quite a heavily pretreated population, with more than a third of patients receiving more than 4 lines of therapy at the time of enrollment in the trial. And without any surprise, exon 11 KIT was the primary mutation at diagnosis for a majority of patients. So compared to sunitinib and regorafenib that have overall responses less than 5%, the ripretinib group seemed to have doubled that with an objective response rate of close to 10%. And this translated into value into an improvement in disease progression with an 85% risk reduction of disease progression and a median progression survival going from 1 month to 6.3 months. And this improvement in median progression-free survival also translated into an improvement in overall survival of a 64% risk reduction of death compared to placebo, and a median in overall survival improving from 6.6 months to 15.1 months. And for patients crossing over to ripretinib after progression on placebo, we see that their median overall survival does not overlap, therefore stressing the importance of offering ripretinib as early as possible in this patient population. And in terms of tolerance, the most significant adverse effect that's different compared to all previous therapies in patients is alopecia, which could be sometimes problematic, especially for female patients. However, other side effects were minor and being predominantly caused by tiredness, a bit of nausea and diarrhea, but thankfully no serious side effects were noted in this trial. So therefore, I would consider ripretinib as a very tolerable drug. And this was also translated as an improvement in the quality of life data. So comparing patients on placebo, we see that patients on ripretinib had maintained a good quality of life, while those on placebo had a dwindling quality of life due to cancer symptoms progression. And looking at translational science in the Invictus trial, we see that patients carrying in their circulating DNA either primary exon mutations, KIT 11 or KIT exon 9, or secondary resistant mutations, all groups benefited from the ripretinib as it was designed to do. Now, for patients progressing on ripretinib, dose escalation showed a limited benefit, but still 26% of patients were still on the double dose at the 6-month mark, but the median duration of treatment was 3.7 months. So there's still an unmet medical need to meet for this group of patients progressing now after 4 lines of therapy. So I'm happy to say that in 2021, we have an increased available options. My colleague, Dr. Kang, will present soon the data on the line Avapritinib and its place in the treatment algorithm. But as we stand today, we now have 4 good options that are responding and help in filling the void of secondary resistant mutations, especially with the arrival of ripretinib. And as you could see, since 2002, we have made quite a leap forward in the last 2 years with the introduction of avapritinib and ripretinib. And when we look at ripretinib and its improvement in median progression-free survival, as well as the improvement in overall response rate, we see the rationale of trying to bump up ripretinib now in the 2nd line. So I'm very excited to see data coming out from the INTRIGUE trial in the next year or 2. And just to touch base a bit on access in Canada. So in Canada, we do have access to Imatinib in the 1st line. Even double dose at 800 milligrams is permitted for patients presenting either progression on 1st line, though we could debate that it's quite, if they don't have exon 9 KIT mutations, we better switch to 2nd line sunitinib. Sunitinib and Regorafenib are also readily available. Ripretinib has been approved by Health Canada and is currently accessible through a special access program. So it was submitted for reimbursement, and maybe by the end of the year or early 2022, we should have results. And I'm quite confident that it will be reimbursed. And Avapritinib also remains accessible through a special access program for patients presenting D842 mutated just in the PDGFRa. So I thank you today for your attention, and I'll let Dr. Kang carry on with the difficult task of telling us what to do currently as standard of care for patients not progressing after 4 lines of therapy.
Okay. Okay, do you see my slide?
Yes, there is an ability at the top to change the way it's viewed on the screen. Is there an option at the top? I think it's in Korean, so I don't remember what it's called, but yeah,
Okay.
I think that's there, and maybe it's called duplicate.
Okay, duplicate. Oh, okay. Fine.
Perfect.
Okay, thank you. Good morning and good evening. I am Kang, a medical oncologist working at Asan Medical Center, Seoul, Korea. It's my great pleasure to join this Life Left Group conference. Dr. Noujaim have already talked about the 4 standard TKI treatments for GIST. I will talk about the 5th standard agent, Avapritinib, first. And then I will talk about the resumption of Imatinib after failure of all available effective treatment. And lastly, I will briefly comment on the surgical resection of residual lesions after control with Imatinib. PDGFRa, D842V mutant GIST is notorious for the resistance to standard TKIs. Here you see our study on the efficacy of Imatinib for PDGFRa mutant GIST. Among the 5 D842V mutant GIST patients, as you see, there was no objective response, while the other PDGFRa mutant GIST patients, about 70% of a response rate, which is similar to the usual KIT exon 11 mutant GIST. And as you see in the left lower figure, all the D842V mutant GIST patients had very rapid disease progression and short survival compared to the other PDGFRa mutant GIST. The Avapritinib, previously called as BLU-285, is a highly potent and selective inhibitor of KIT and PDGFRa activation loop mutants. In terms of IC50, which is a drug concentration to inhibit 50% of target, the Avapritinib was the most potent compared to the other standard TKIs, Imatinib, Sunitinib, Regorafenib, in inhibiting D842V mutant, as well as KIT exon 17 D816V mutation. On the right panel, you can see also the tumor regression was the most prominent with Avapritinib. And Navigator study was the phase 1 trial of Avapritinib in unresectable or metastatic GIST. The 56 D842V mutant GIST patients were included in this trial. And over 90% of response rate was reported with Avapritinib. And the response was very durable for median about 2 years. And median progression-free survival was also 2 years. This table shows the adverse events experienced in these patients. The most common adverse events were nausea, anemia, diarrhea, and fatigue. And also this agent is quite unique among the other TKIs for GIST to have cognitive side effects. And the most common cognitive effects was the memory impairment. And there is some patients who experience intracranial bleeding, but it's very rare. So the in a Navigator study, also the Avapritinib also showed the efficacy in patients with advanced GIST with 3 or more prior lines of therapy. As you see, in these patients, about 17% of response rates and also 38% of disease control rate was observed. So the phase 3 VOYAGER study has been conducted to compare the Avapritinib versus Regorafenib for patients with the 3rd or 4th line GIST. But unfortunately, the study did not meet the primary endpoint of progression-free survival. The Avapritinib was not better than the Regorafenib in progression-free survival in these patients. So in summary of Avapritinib, the Avapritinib is the highly effective for PDGFRa exon 18 DA42V mutant GIST. So it's approved in US for the treatment of PDGFRa exon 18 mutant GIST, and also in Europe for PDGFRa exon 18 DA42V mutant. For the other genotype, however, the Avapritinib was not better than Regorafenib for the third-line treatments. And regarding the adverse management of adverse events, the early recognition of adverse events and tailored dose modification appear to be effective, and dose reduction does not appear to result in reduced efficacy. And patients' cognitive functions should be assessed at baseline and monitored carefully throughout the treatment. And the dose interruption is recommended at the first sign of any cognitive effect, including the grade 1 events. Finally, I'd like to say that the DA42V mutant GIST is often quite indolent tumor, so it is not necessary to start Avapritinib immediately after the metastasis or recurrence. I have several patients with this DA42V mutant GIST with metastasis who are just in observation without treatment because of very slow progression. Next, the rationale of the resumption of Imatinib after failure of all available TKIs as follows. According to the principles of oncology, rechallenge of any chemotherapeutic agents is not recommended if those agents have failed previously in the patients. But the expert consensus recommends a rechallenge of a TKI that failed previously in GIST. It's because we see a flare-up on the PET scan after discontinuation of TKI, and among the multiple clones present in the patients, some are still sensitive to TKI even in case of progressive disease. And also the retrospective studies suggested potential benefit from a rechallenge of TKIs after a prior failure. So the phase 3 RISE study was designed. The patient with prior clinical benefit from the first-line Imatinib and progression with both first-line Imatinib and second-line Sunitinib were randomized to receive either placebo or Imatinib. And at the time of progressive disease in the placebo arm, the crossover to receive Imatinib was allowed. And as you see, Imatinib rechallenge prolonged progression-free survival significantly after failure of all available therapy compared to the placebo. Although the absolute amount of benefit was not large, the median progression-free survival was 1.8 months in Imatinib arm and 0.9 months in placebo arm. Lastly, let me talk about the surgical resection of residual disease after control with Imatinib. Pathologic examination of the resected specimen usually reveals that most of the grossly residual lesions contain suppressed but viable cancer cells, and the clinical resistance to Imatinib can develop from these viable cells present in this grossly residual lesions, if not resected. So the resection of these residual lesions can prevent or delay the emergence of clinical resistance to Imatinib. To assess the efficacy of surgical resection of residual disease, we have conducted a retrospective study, and we have compared the treatment outcomes of 42 patients who have resected their residual disease after control with Imatinib, with the 92 patients who did not resect but just continue Imatinib, and found that the resected patients have significantly better progression-free survival and of the Imatinib, and the overall survival. And this resection was also found as an independent good prognosis factor in the multivariate analysis. Further, we have recently reported long-term survival outcome of about 400 GIST patients who studied Imatinib for metastatic or recurrent GIST in our institute between 2001 and 2014. As you see, we could confirm quite good results. Median progression-free survival with Imatinib was 5.4 years, which is much longer than the reported before, about 2 years. And also the median overall survival was 8.8 years, which is also quite longer compared to the reported before, about 5 years. And we also compared the treatment results between the early and late periods in our study. And as you see, the results were significantly better in the recent period. And I'd like to draw your attention to the right panel, the progression-free survival with Imatinib. You can see a much better trend in progression-free survival in recent years. There can be many reasons for the improvements, but I think that the most contributing factor for this improvement in the progression-free survival with the Imatinib is a surgical resection of residual lesions after control with Imatinib. In total patients, about 20% of patients in our the patient population had resected the residual lesions. And comparing the two periods, as you see, resection was done 2 times more in period 2. So in summary, the Avapritinib is highly effective for the treatment of a patient with PDGFRa D842V mutant GIST and became the standard treatment for this mutant. Secondly, resumption of Imatinib is a treatment option after failure of all available effective treatment. And lastly, the surgical resection of residual lesions is beneficial after control with the Imatinib or metastatic GIST. Okay, thank you very much. And then
Thank you for those presentations. Really appreciate it. We're now going to transition to